As we mentioned during the introductions, we're going to share today some of the various projects that we're working on funded through the state opioid response grants. Next slide. Sheena Sayers was also supposed to be here today. Unfortunately, she had a conflict with her schedule, but she helped put these slides together, including the data that we'll discuss in this. As typical, we want to acknowledge our funding source for these projects that we're going to talk about. This is a SAMHSA grant that is passed through the West Virginia Bureau for Behavioral Health. As typical, we are not expressing the official policies or necessarily the views of West Virginia Bureau of Behavioral Health, but we do appreciate their support for the funding to allow us to do some of this work. Next slide. This is just an overview of the current SOR team members. These people have partial or full salary paid by the SOR grants. The grant management team really deserves the majority of the kudos. Sheena, I'm sorry that she couldn't be here today. She does an excellent job as the program director and runs along with the grant management team day-to-day staff. As the PI, I only really get involved if there are big decisions or if there are problems, and really there are hardly ever any. So Sheena, Megan, Andrew, PJ is the lead peer recovery support specialist and does so much, has such great networking, and is such an amazing benefit to the grant management team. And then JW is our most recent addition, and he is a research and data guru. He's really made a great addition to the grant management team. We also have some other support from different divisions, not necessarily in COAT. Dr. James Mahoney is a PhD clinical neuropsychologist, and his expertise in things, for example, like contingency management, are just so great. He's helped a lot with the training of other SOR grant recipients across the state on contingency management, theoretical and implementation. Mickey is our newest member. I don't know if he's here today, but he is recently hired as the regional jail coordinator for the northern part of West Virginia, and we'll talk about that specific project at the end. He is a certified addiction and drug counselor. He has like over 20 years of experience in addiction care management, including managing and administering an IOP program in the state of Pennsylvania. So we're really looking forward to working with Mickey and having him part of the team. Stacy is a leader in the PBRN here at WVU. She has great connections with sites, clinical sites across the state, and has great insights on organizational relationships and networking and research. Jay Mason, I think probably most of you know, is with the West Virginia CTSI. He is like the echo extraordinaire. He knows so much about echo and IT, and has really great insights when we're working on projects together. And then our clinical team, I think probably most of you know the clinical team. Dr. Barry's our chair of the Department of Behavioral Medicine Psychiatry. He's been my personal mentor from a clinical standpoint in addiction medicine and addiction care. He's also he's the PI on the Impact Project that we'll talk about in a second. Billy Vance is a colleague of mine, nurse practitioner, and she's been helping. She does clinical care and COPE, but she's been a big help to the quality improvement team. Katie, Laura, and Olivia, I believe you all have seen or met them during these ECHO sessions. They're all therapists and have been working on these projects from the very beginning. Olivia also has experience as a case manager, so she brings kind of a dual perspective into the projects. James, Tara, Will, and PJ are our peer recovery support specialist, and Dr. Owen Lander and Dr. Brian Dilcher are our physicians in the emergency department who have championed the Impact Project and been central to the design and implementation of that work. Next slide. So these are the projects we're going to briefly hit on today and share some of the data that we've gotten from the work on these projects. The MAT/code expansion, most of you are familiar with. It is a project to expand the use of the particular model that was founded here at WVU Medicine around 2010, I believe. It was first started, this model, by Dr. Raleigh Sullivan, who and it has evolved through the years. The goal was to this model is a group-based model that uses interdisciplinary professionals to address opiate use disorder through the use of medication, therapy, and social support. An impact project is utilizing the concept of motivation, peer recovery support specialist, and a point of entry into healthcare, namely the emergency department, to rapidly address and integrate patients into ongoing care, whether that be inpatient or ambulatory care, as well as induct patients in the emergency department when appropriate with buprenorphine. The Center of Excellence for Addiction Treatment is an umbrella group that really focuses on technical assistance, education, and quality care related to addiction. And that project is evolving this year a bit. We'll hit on that in a moment. The Uninsured, Underinsured Support Grant project is exactly what it says. It provides financial support to people that do not have the financial resources or are not insured, and addresses that barrier to care. The regional jail coordinator I mentioned, Mickey, is our new coordinator, and we'll talk about that. And our newest endeavor, which is just rolling out, is a mobile treatment unit. Next slide. So as I mentioned, the coach expansion was the very first project under SOR, and it's a modified hub and spoke approach. If you look in the literature on hub and spoke approaches, historically, initially, they were more focused on the hub treating patients with higher needs, needing more acute stabilization when they're in active addiction. And then once that occurred, sharing the care with a quote spoke. So other sites, once the patients would be stabilized, would take over the care. Vermont, I believe, was the first state that really used that approach. What we did was modify it a bit, in that a patient wouldn't be dictated to go to a hub or a spoke at all based on their acuity of care as far as ambulatory treatment, but more so a regional and local approach, that people could be qualified and trained to take care of patients regardless of their level of care need, again, as long as it's ambulatory. And we would support and train these clinics across the state to utilize the COE model, and then provide ongoing engagement, including with ECHO, this SUD ECHO, where people can present difficult cases that they would like, an informal consult on, or discussion about treatment options. And 2017 was the very first year, late in the year, and we had hub identification and implementation. And then today in 2023, we have 18 hub and spoke sites. And our goal this year, by the end of the grant year, is to add 2 additional sites for code expansion. Next slide. So this was clinics utilizing the COE model in 2017. Next slide. And this is the model implementation in 2023. You can see it's a fairly robust geographical kind of spread. There are some areas that we would like to get the model integrated in, but all in all, it's a nice spread across the state. And I think Megan's going to talk about some of the data and some of the other projects.
Great. Thanks, Tony. So just looking at this timeline, our COE treatment grant, like Tony had said, began in 2017, at the end of 2017. So we had a total of 4 hub sites that had signed on, with only 2 patients enrolled into the grant program at that point. And so as you can see over the years, we have expanded from 4 hub sites, which I do apologize for the typo. It should say in 2022, 18 sites, but we have 18 sites total. And we have seen over 3,000 unique patients since 2017. So each year we've probably seen about 700 new patients who have not yet been enrolled in one of these co-programs. And we're hoping to continue to expand that with 2 more sites. Next slide, please. Right, and so I'm going to talk a little bit about the IMPACT project, also known as the Initiate Medication, Peer Assistance, and Connection to Treatment. So this was a collaboration between WVU Medicine and the Ruby ED, as well as now Fairmont and the Department of Behavioral Medicine and Psychiatry. So with that, the peer recovery support specialists are staffed in the emergency department. We currently have 4, which Tony introduced in a previous slide, and our goal is to have a total of 6 to be fully staffed. And so what the peers do is they go into the ED and they go and they speak to patients who may be appropriate for treatment, and they assess them. And they also provide support, contact information, and can facilitate them into a treatment facility if needed. And so one of the other things on top of that is we can also initiate buprenorphine in the ED if it is appropriate. So our ED providers that we collaborate with can administer buprenorphine while they are admitted to the emergency room, and they can also write bridge prescriptions from the ED to the date of intake if they are going to be going to some sort of outpatient facility, including Chestnut Ridge COTE. So if a patient comes in on a Friday afternoon and they need to get into the COTE clinic, but the next intake isn't until Monday at 9, what they'll do is they'll write a prescription for that weekend, so that way they don't go through withdrawal, end up back in the ED, and then they can make it to their appointment. All right, next slide. Thank you. So this is just a little bit of data about the IMPACT project. So the graph on the left is just looking at the patients that were seen by the peers by month. And as you can see down in the bottom left corner, I know it's kind of small text, but we started in March of 2020, which, as all of you know, that was a very chaotic month with very chaotic months to follow. But our peers did a great job navigating through COVID, going in to see patients during that time. But it was about like 8 or 9 months before we really saw a jump in the peers seeing a lot of patients. And so we started seeing about a year in, them seeing anywhere from like 70 to 80 patients per month to connect them to treatment. And as the peers have done a wonderful job of connecting them to treatment, that number has now slowly been dropping. And so now as of March 2023, we see about an average of like 50 to 60 patients per month that the peers see. And then here, the graph on the right here is showing patients that were administered buprenorphine in the ED, comparing it to the percentage referred for buprenorphine. So the important thing to look at here is the red line. So that is showing that all the patients that were referred by the peers to receive bup, that were deemed appropriate for receiving buprenorphine, that were administered, and we've been seeing a positive trend from about 50 to 60% in 2020 up to about 70 to 90. Next slide. All right, so moving on to the Center of Excellence, which is a different project that we have under the State Opioid Response Grants. So we have the Center of Excellence for Addiction, which, like Tony said earlier, is more focused on technical assistance, education, quality improvement. And so we have 4 big projects that we work on under this umbrella. So the first being contingency management, where we have local implementation in our COPE program and also provide training for other sites to implement it in their clinics. We also have the NIATEX quality improvement model that, again, we implement in our own COPE groups and can provide training for as well. One of the other projects is identifying systems level inefficiencies, which is looking at external and internal barriers at different facilities for providing quality treatment and working on reducing or eliminating them. And then the last one, which is this big square of text, the interdisciplinary health professional students, intensive education and addiction treatment. So what that means is we have our interns, under the Center of Excellence. So we actually just started last week, our 4th cohort of students who are on this ECHO today. We have med students, nurse practitioner students, MSW, and Master of Counseling students who participate in observation of all modalities of addiction treatment, from inpatient all the way up to like monthly groups. And so then the next steps, the next steps for the Center of Excellence is to pilot enhanced services. So looking more at personalized care navigation with embedded quality data tracking and exploring alternative payment models. All right, next slide. Thank you. So this is our project working with the NIATEX model to have a quality improvement project. So the goal of this project that we have in our COE group here at Chestnut Ridge is to increase 30-day patient retention. And so what we did by using the NIATEX model is we developed an orientation group for patients that are just entering treatment. And so what this orientation group does is it kind of teaches patients how to be in COE groups. So, what the general rules are, how to use Zoom since we use telehealth, how to use Zoom if they have any kind of barriers to any parts of treatment, of resolving those before they go into a full weekly group. And so with this project, we found that there was an increase in overall retention from 43% to 52%, which on paper that a 9% increase doesn't sound like a whole lot, but looking at our patient numbers, that is an extra 31 people that we had in treatment that made it to the 30-day that would otherwise not have. And then this chart over here just kind of shows some general retention comparing 2020 to 2022's numbers of patients making it to their 10th appointment. And we're seeing some good increases there, and hopefully it keeps improving. Right, next slide, please. All right, and then another piece of the Center of Excellence is we began a QI ECHO cohort with the help of Jay Mason and our COE team. So what we do is we provide quality improvement technical assistance. And so we have had 2 cohorts over the last year. The first with Northwood Health Systems and Community Care of West Virginia, and the second cohort being New River Health Association and Cabin Creek Health Systems. And so what we did with this cohorts is we had them come up with an idea for some kind of change that they wanted to make to improve, like, treatment or retention or whatever. And we helped them build the project through the NIATEX model. So we helped them build a change team, pick their aims, how they were going to implement their intervention, and how they were going to evaluate that intervention. And one of the good things with the NIATEX model is now that they know how to do it, moving forward, when they have any future quality improvement programs they want to implement, they can do it. They know they have the necessary tools to do it. Next slide, please. All right, and so one of the other projects that we have under the Center of Excellence umbrella is our contingency management implementation that we have here at Chestnut Ridge with our intensive COE and our pregnancy COE groups. So we offer incentives for patients to attend group, attend individual therapy, attend individual therapy, and either attend their UDSs or have a negative UDS. And so just by providing those small incentives to change their behavior through positive reinforcement, we've seen some pretty good results in improving that retention and negative UDSs. Next slide, please. All right, and then just kind of following up with the contingency management on the other side, we are also providing technical assistance to implementing contingency management programs throughout all of the SOR grant recipients. So with all of our hubs and spokes, they have all begun implementing contingency management. And so our next steps are to start working with other SOR grantees that were not under our umbrella to help them implement plans for contingency management. And since 2022, we have provided 36 sessions of technical assistance to various sites, and that doesn't include just contingency management. So we also help with program planning, we did clinical consultations, and we also did some quality improvement as well. Next slide. Okay. And so for the next steps for the COE, we're going to kind of step away from the technical assistance side and move towards more enhanced care management services. So focusing more on services and holistic care coordination for patients and treatment through a care navigator. And so that care navigator is going to work on improving social determinants of health and full continuum of care. So getting patients connected to housing, education, their PCP, and that's done through very warm handoffs of connecting them to treatment, making sure that they have the appointment, making sure that they're getting to those appointments. And so with that, we're going to measure the impact on treatment retention and then the outcomes and total cost of care. Next slide. And I think I'm going to pass it back to Tony here to talk about the underinsured, uninsured.
Okay, thank you. And just one thing to mention about the next steps in the Center of Excellence, the COE, and what Megan just described as moving towards either like care navigation or care coordination or care concierge, however, whatever title you would want to associate that with. The ultimate goal is to see, number one, what the cost of hiring someone like a social worker, a nurse, someone trained in humanities, and hopefully having expertise in addiction, and doing that networking and care with a dyad, a second team member of a peer recovery support specialist. So those two, like how many patients can they take care of with the goal of having like 2 hits a month, like at least 2 contacts a month with those individual patients to assess where they are, what they need, how we can help beyond what we do now in COE. And so looking at the cost of doing that service and seeing if a model of payment, a capitated rate, in addition to what we get already when we bill insurance companies, adding to that a capitated rate, like X number of dollars per patients per month, and seeing if that together, that cost together to the healthcare system is actually lower than the total cost of care for those individuals that are in treatment. Plus, are there improved outcomes? Are they healthier? Do they have extended sobriety? Are they advancing to bi-weekly, weekly, monthly, bi-monthly faster than if this service wasn't offered? Because we all have case managers that help immensely with the management of patients in clinic and the coordination of our groups, and help immensely with patient care, but they can't be everything, they can't be everywhere, and they can't do it all. So we're hoping to, and we had some success. There was we did hire and her funding, I believe, is no longer under SOR, but we piloted a CPS liaison, where a part-time staff member who helped our patients that are interfacing with CPS for cases, being kind of a facilitator, an advocate, a coordinator of that connection. And that model has worked out very well. And certainly the patients that have worked with Anna Butcher, who is our liaison, have had great things to say about it. So we're hoping to expand that beyond just the CPS caseworkers. So back to the slide, sorry for that diversion. Uninsured, underinsured program is just a pot of money basically for people that deal with financial barriers to treatment. They can't pay, they have no insurance. And I don't know about you all, but here we have had a big surge in patients on Medicaid who they weren't reevaluated because of the public health emergency. So they were automatically getting Medicaid. And now they're either getting released because they make too much money, although that's the minority. The majority of the people that are losing their Medicaid right now is just because they're not doing the recertification, the reevaluation because of poor contact information. The DHHR does not have their correct, they can't get a hold of them to validate if they still qualify or not. And we are seeing a lot of these people that we are using this fund to tap into, for example, to pay for their prescriptions for MOUD, or if they need help with co-pays for their urine drug screens, particularly like the alcohol metabolites, ETS, ETG are pretty darn expensive tests. And people with high deductible insurance that are not reaching that deductible, sometimes $8,000-$10,000, whatever can be their household deductible. And, you know, they're just over the line to qualify for Medicaid. This helps them quite a bit. So it can also help with patients that say need additional time in the hospital, determined by their providers, their physician that's caring for them in the hospital. Say the insurance will only pay for X number of days, but they really, for medical reasons, need to stay longer. This fund of this pot of money, this fund can help make sure that they get the appropriate care and that finances are not the barrier to them receiving that. Next slide. As I mentioned, this regional JARE coordinator program, there's actually, Mickey is our regional JARE coordinator. He's going to be taking care of 4 jails in the northern area of West Virginia. That's North Central, Northern, Central, and Tigard Valley. So Mickey will be the regional JARE coordinator for those jails. And we will also be partnering with other sites, maybe some people on the call who employ peer recovery support specialists that support these individuals that are coming out of incarceration and are interested and need treatment. This is a voluntary program. So we're looking at probably people like 90 days or closer to release that say that they want this care, they want this service. Mickey would go in person to the jail and do an in-person assessment and determine, you know, re-entry plans, safety plans, relapse prevention plans, a recovery capital assessment. We're still kind of refining exactly all the tools that Mickey will be using for assessment, come up with a care plan or care plan recommendations. And then when that person is released, a peer recovery support specialist, say from Northwood, for example, I know they're facilitating the care of people released from Northern, would take over the day-to-day implementation of that care plan. And Mickey would be there to support and assess quarterly how things are going. Obviously, the goal is to keep people healthy. Post-release from incarceration is a very, very vulnerable time. There is a very high rate of overdose deaths during that period. So we want to prevent that and help make the transition as smooth as possible. So Mickey just came on maybe a week, 2 weeks ago. And so he's gearing up and we're going to be starting these services very soon. Next slide. And then our newest endeavor is, and I know other places across the state, maybe some of you on the call have already entered into this realm of care, this mobile treatment units, and we're looking to enter that. Initially, we're probably just looking at Mon County, Marion County, Taylor County, just, you know, in Preston County, those 4 counties, and looking at providing services to people that are currently underserved and in high-risk populations, for example, veteran populations or very rural populations who aren't necessarily accessing care currently. This probably won't, this is not intended to be targeting our people in current care that just are inconvenienced by transportation, although we know that is a big deal, this transportation, but this is actually doing outreach to get people into new care, to establish with new care. And we're also looking at improving other points of care for perhaps contraception, primary care, wound care. And so we're in our very, very early stages of this mobile treatment unit. We've talked to several different clinics with mobile treatment units across the state, and DHHR has been great with supporting and getting all of those individuals and clinics together to talk about what they're doing and making sure, you know, just making sure that we're not duplicative of services, and talk about what's working well and what's not working well. And our overall goal is to decrease overdose deaths and rates in general, particularly in hotspot locations of those various counties. Next slide. I think that's it. And I think these are not my dogs. I think these are, Megan, is yours the darker dog and Sheena's is the light dog?
Yeah, that's Callie on the left and then Asher's on the right.
They are very cute dogs. I think I saw some questions. I have not billed those chronic care management codes. Have you? I mean, I know in primary care it was done at clinics I've worked at in the past for things like CHF and COPD. Have you done it in this, Dr. Beltier, in this?
I haven't, because we haven't for anything, but that's money that we're potentially leaving on the table if a physician or clinician is involved. And since many of our programs are integrated, whether it's with, using the buprenorphine or other things, we could be, and I guess I'm looking to compare that as a baseline for your capitated model, because I know that, for example, now in West Virginia, we got drug-free moms and babies, you get a little bit for that. You can get for mental health care coordination if you're a behavioral health center, for example. But I haven't, but I think it would be interesting. I was trying to pull up what because honestly, a lot of this is West Virginia Medicaid. That's the truth. We can look at other payers and stuff, but if they had codes for that under their, relative base value system and all that. So I think that would be the first question. I think they do. And then, the guidelines are, it doesn't have to be the clinician, it's per staff, and it's every 20 minutes, then 30, 60, et cetera. And if the clinician actually is involved, which I would suspect many of us are, and just don't bill it, you don't have to see the patient, but it's care coordinating. And there's different levels of complexity. There may be funding that may be able to help pay for some of this staff. Again, and it's you get in the weeds and you forget to look at where do you get money from, so I think it's something I'm going to be looking into, because we do a fair amount of, it's phone work. Basically, you're on the phone, you're coordinating, you're calling other entities. If our peer coaches are part of the system and they're calling around, they're spending hours, sometimes a month. And so we could be billing under, kind of the medical system. So anyway, just something that I've been thinking about, was wondering if anybody else has done that or not. So.
That's a really interesting idea. It's horrible to say, I've never even thought about those, because I am, like I said, familiar with them in the context of other chronic diseases. And, we know that substance use disorder is a chronic disease, and I never put the two of those together. I mean, I just never even thought about it, doing that or trying that. But now that you mentioned it, I am going to look up if there are limiting diagnoses that you can, and at the very least, find out what the reimbursements are for that.
Yeah, it's just a chronic disease. I mean, because the American Academy of Family Physicians puts that out. So, I don't think, I mean, there obviously are limitations, but, it doesn't. Yeah, I can send you what the AFP has, Tony, because I know you're into this stuff. And then if I'm looking to try to get the codes in West Virginia Medicaid manual, if those two match up, then there's your dollars. They actually tell you what they pay per visit. And then
the problem with that for us, though, is because we're, how people are registered through, and payers is behavioral health is registered, and it is enrolled or credentialed or certified, whatever you call it, in a different way than physical health. They categorize them different. And I wonder if they would allow us to submit those codes as behavioral health services.
Right. Yeah. And again, it may be, so my situation's a little different because we're medical, although we do so we're medical doing behavioral health, you're behavioral health doing medical. And then for community health centers and rural health clinics, staff, they can get paid based on outreach as well. They get paid a unit-based payment, which right now for rural health clinics, I think is about $120 a visit. So potentially a nurse LPN visit to that patient or contact video could be reimbursing that much, just depending on if the physician's involved or not. And then FQHCs are actually a higher rate than that. So just the one way around that, because we are starting to see people dropping off Medicaid rolls, and some of it is income, but a lot of it is they're just MIA. And so I'm a little disappointed in my system that we haven't done anything proactively. We know who these people are. Somebody does, the computer does, and that we haven't pulled the rolls and said, here, these are the patients that need. Some other health systems have done that just out of self-preservation. If we go from, I think before the pandemic, we were probably running anywhere from 6 to 12% uninsured, and we went to under 1 to 2%. That's big numbers that have dropped and that are going to go right back up. So I think proactively, somebody who could data mine that for us in contact, because we have contacts for those patients. We see them for the buprenorphine and their visits. So if they gave us those people, and I'm trying to work with our registration people to say, because it can be pulled up when they register, when their Medicaid expires, and just helping them through that process. Instead of, oh, now you've lost it, and recovering it is it's a whole other thing. And from talking to people, Medicaid's not answering the phones, they're not answering emails. I hate to be cynical, and I think Laura heard me earlier today. Today is a cynical day, but if you are a little bit, this may be a purposeful thing. I think it's benign neglect, honestly, but it's just, there's nobody interested in this population making sure that they're staying ahead. There's no incentive to keep them on Medicaid.
Yeah, I mean, we're definitely seeing that. I mean, seeing those drop-offs. And I read an article this week, like maybe 45,000 in the past 6 or 8 weeks have dropped off the rolls, but like 40 of those 1,000 are because of what you're talking about, not because they're making too much money, just because there's no coordination and recertifying. It's crazy.
Yeah, that's big, because I don't know if anybody knows the number of patients in West Virginia that are on Medicaid. It's at least, I'm thinking 100 and some thousand to 200,000. It's big. So that's at least a quarter of the people that have dropped off. That's probably pretty conservative. So that's having an impact statewide and for hospitals that are running budget issues in medical systems.
Oh, for sure. Dr. Arvin, so we've been sending folks to the West Virginia Navigate. Yeah, I was asking about that the other day at one of our meetings. Do we still have West Virginia navigators for, the Affordable Care Act? And I didn't know that patients could just call 211, because I was trying to dig through that for some local navigator, and it was a little difficult to find. So people can just call 211 and say, I need a navigator to get on the exchange to get insured.
Yeah, we had our West Virginia First Choice service person here, Taylor, who's here in Berkeley County, came out here to do a presentation, and she said, like, all you have to do is call 211, and they can get you hooked up with whoever you need. They have all the different programs, but they can get you hooked up with the insurance navigator or whatever, and they'll do whatever they can to help them. So.
Oh, that's great information. Thank you.
Yeah, and I had a patient who went through who lost her Medicaid, was having to pay $800 a month for insurance, and went through the navigator, or the West Virginia helpline, and they got it for $200 or $100 and something a month. So they are there. So it is still working, I think.
Great.
And Jordan just put in the chat. Wow, the Medicaid numbers, 600,000. Wow.
That's huge.
Yeah.
That is a third of our state is on Medicaid. And the codes I put up there, the ones I saw that I could find, the physician code, which is the last one, is not covered by Medicaid. And the other ones aren't on the list, so probably not covered. So unfortunately, unless they're covered under something else, some other service. But the insured So the insurance companies that run Medicaid, United Healthcare, et cetera, are interested in saving money. So your capitated plan is good because I think they're the ones helping to pilot the doulas, the breastfeeding, the drug-free moms and babies are getting some money because they want to save money. And so I think other states have done the capitated model entirely for Medicaid. So I don't think it's unreasonable to do that. And I don't think it would be unreasonable $100 per patient per month with a supplement for addiction of 25% or something like that. At 125 per patient per month, you can do a lot.
Yeah. That's like Pennsylvania has their center of excellence is really based on a payment model with care and a payment model, but basically these different centers of excellence register with the center that's coordinating it all. And what is built in is also data analytics that they share, the clinics report, and then the central data analytics site, processes and gives back, including comparative analysis, like how you're doing compared to other clinics of excellence. And I believe now this is Pennsylvania, and I know it's different than West Virginia, but I believe their capitated rate, and this includes the data part too, so not just the care on that, is 236 or 263. I'm
Wow.
patient per month. Yeah. Now that includes the data analytics part too. So it's not just care, but I don't think we would ever get paid that. But my point is that could be spent very, very well. That money could be beneficial.
Yeah. So at 100 patients at $100 per month per patient, which is a reasonable number. If you're taking care of 500 patients, which is not unreasonable for a primary care provider, it's $600,000 a year. At your rate at 200, it's 1.2 million just for 500 patients, which is kind of the number of a concierge practice, which is what we're talking about here. It's concierge for addiction. So I always say Medicaid patients deserve concierge medicine, which is what we're providing for them, concierge behavioral health and addiction services. And so those numbers are just for people to know, those are good legislative advocacy numbers. So I think that's great that our neighbor's doing that rate. So they're probably spending 100 to 150 and then other data, et cetera. And so it is doable. And you can pay people good salaries to do that care.
Right.
And I know Dr. Hirschler put something in the chat too. I don't know if you want to unmute and say what you put, Dr. Hirschler.
Yeah, so I was just asking about, or kind of suggesting that I think the Center of Excellence should focus some on case complexity and see if we can identify better what the needs of patients are and which needs we have gaps in care and unable to meet, the needs we can't meet, so that patients have better outcomes.
When you mean case complexity, you mean from a medical standpoint or from a like SDOH standpoint?
There's lots of ways to get. I actually am giving a talk in ECHO coming up in August about case complexity. So there's lots of routes to complexity. It can be from psychiatric comorbidity or medical comorbidity or cognitive impairment or social determinants, or it can be from someone being a professional who is impacting a lot of people. It can be there's lots of routes to case complexity, multiple drugs, so up or downer pairing, and multiple substances or multiple addiction types like sex addiction or gambling, or so whatever the needs are.
Yeah, thank you. That makes good
And
sense.
Jeremy, some other places have actually incorporated that into their electronic health record, where patients are green, red, yellow. The red patients, whatever percentage, and you determine that, and they have that, whether it's social determinants of health, number of diagnoses, what's always dual diagnosis, which there's different definitions of that. I agree. We really need to be proactive on that.
Yeah, I think if we can meet the needs of the complex cases, then we're really ready for anything. And so, but we should definitely focus on how cases get complex, and then whether we can meet those needs or not. And if we can't meet the needs, how we can find the right people or the right services to meet their needs.
Any other questions or comments? Anybody want to share, like, because I know a bunch of sites, like I don't want to put you on the spot, Jennifer, but I know that you're like working with a drug court, and I didn't, I just know other people are doing very cool stuff too, and wanted to offer this time for other people to share what they're working on.
This was really interesting. I wanted to say, to see the presentations and to hear the conversation. In my opinion, one of the more exciting things that we're doing and interesting is working with the adult. I call it adult treatment court. They call it drug court, and the family treatment court here in Fayette County. And our local our judge, he went through the ECHO program. Is Jay on here? Jay, among other ECHOs, does a judiciary ECHO that works with judges across the state. And so we actually get a lot of referrals, relatively speaking. We have a small program, but if you went by percentage of people who are coming into our program and staying, it's those from drug court. And it's a little bit complex because they're not, you could say they're being mandated to come to treatment. On the other hand, they chose to participate in the drug court as opposed to go to jail. And so in some ways they're in on the choice. And it really feels like a treatment team, at least in Fayette County, the judge and the social worker, who's a probation officer who sort of run the program, are really thoughtful and keep themselves educated. And so at any rate, I don't know, I could always answer more questions about that, but I think that those programs are expanding across the state. I know that Fayette County was not the first, but one of the early ones to do that. And I wondered when I was hearing about your program to help people who are leaving incarceration, which that is so important. I just heard this month, about a program here at Southern Regional Jail called the Goals Program, that's while they are incarcerated, that is really has been very successful, and took some of the people who were in the drug court system and really could not make it, and then went to jail and achieved sobriety through this program and are doing fantastic. So I don't know if you all, I forget what Goals stands for, and I need to find out more about it. I don't know if anybody's aware of that program.
I'm not specifically. I have heard about different programs, and I know that the DHH, there have been changes in the West Virginia Department of Corrections and some roles and leadership, and there's a lot more interest and engagement, and it's going in a good direction. I don't know that program specifically, but I have heard about some things going on that were positive like that. And I've had a couple patients that have gone through a program that really, came out really doing well. Laura, are you familiar with a program called Goals, or a specific incarcerated population program?
I am not. I'm not familiar with that.
Megan, have you heard about that when you've been talking to DHHR and DOC?
No, that one's not familiar. I wrote it down to bring up the next call, but yeah, that's really interesting. I'm excited to hear more about it.
And try to find out a little bit more about it. But boy, I saw two of the young women who went through, and I was flabbergasted at one of them, at the turnaround it made in a very short time. I mean, less than a year. She's employed, and it's really solid in her recovery, and we were all worried she was gonna die. But at any rate, I can try to find out more and let you guys know.
PJ, do you know something?
If I'm not mistaken, they have programs like this that have been in our prison system for quite some time, both on the state and federal level. Here in the state, the ones in the prison system, I drew a blank on the name. RSAT. It's like residential substance abuse treatment that's inside of the Department of Corrections. The Department of Corrections has taken over the regional jails. So they brought something like that to the regional jails, but they're just calling it a little something different. Because if I'm not mistaken, that goals program is like 6 to 9 months or something like that. But they're sectioned off from the rest of the population. You know, they have their own little part of the jail that they're in, and you know, they work on achieving substance abuse treatment goals while they're there, much like they do with the RSAT programs and it's RDAP in the federal prison, RDAP, and RSAT in the state prisons.
Thank you so much. David, go ahead.
So question on your, what you've seen that was interesting to everybody else too. Do you think that you're seeing less people presenting potentially? Because it looks like there was a drop off on the peers and kind of some of the referrals. Is it because we've reached certain people and, they're kind of in treatment? Because I feel that we're seeing a little bit of that. Some, our pregnant women, I can't believe that we've cured the problem, but the easier ones, or the ones that are more receptive to treatment, or have, more resilience, or have, something, we've gotten into treatment, and the ones we're seeing that haven't been in our tougher populations. But it does seem like we're potentially making an impact with the whole hub spoke statewide treat. There's been a big push. And I don't know if you can tell that from your data or not. I know it's really hard because overdoses keep going up and numbers keep going up, but the percentage of people in treatment seems better, or maybe I'm just, we're living in an island. I don't know what your impression was from the data, and then other people's impression from on the ground.
Yeah, I absolutely agree with you. I think that we are reaching people. I think it's a mix. It's hard to say, for sure, this is exactly why, the numbers are dropping, because there's so many factors to it. You can't just, but with as regards to, I'm assuming you're talking about the ED, people we're seeing in the ED, it had dropped.
Yeah.
I actually just sent Tony some numbers not too long ago that I'm pulling up about that the peers have had a direct connection to treatment with 851 patients since the impact program started in the ED. So that means 851 of those guys have made it into some sort of treatment, and have been in recovery or are entering recovery. So I think it's hard to pinpoint exactly, the reasoning for that drop, but I think that definitely it has made an impact.
PJ, what do you think? You're a lead peer and you see this, what's going on in the ED. What do you think about that?
I think another thing that has an impact is the work that we've done on like advocacy and educating people on access to treatment, and also being able to have more places to send them to treatment. I think both of those things have played a role in getting a lot of people, into one type of treatment modality or another. And I would like to think that the quality of care that we're delivering is getting better. So maybe people are staying a little more engaged in recovery and hopefully not having to come back as often. But those are just a few little things that I've noticed.
It really is hard to tease it out when the illicit drug supply is so, dangerous and, very, a short-term use, short-term misuse, short-term recreational use can lead to overdoses these days. So it's kind of hard to dissect, the lesser the number of people in the ED per month, is that because the people that have true substance use disorder are accessing treatment. And one of the big fears initially with the project in the ED was, will people, especially when you're dispensing and prescribing bupe from the ED, will people use this as an access point for medicine and not treatment, not ongoing? Will you get frequent flyers coming back over and over again? And that has not happened at all. Actually, there's been one patient that started concerning our team as potentially a frequent flyer, and it turns out he has significant mental health issues. It's not because he's searching or he's wanting bupe. He had needs with included short-term memory problems. So that's the only patient, I believe, since we started that has made a repetitive presentation that was in any way troubling.
And that's borne out in the national data too, because that's often ED providers' fear, but it's not what actually ends up happening. The ED is not a really great place to go try to get medicine from. It takes a long time.
Especially if you're withdrawing and they make you wait and you get tired of being there.
Yeah, and one of the data points that we look at in addition to what we presented is return rates to the ED. And we've seen over, at the very beginning there was an increase, and but it has slowly been dropping off. The more that the peers connect with them, get them into treatment, the less we're seeing them come back to the ED.
Actually, that is a good data point to discern if people are improving, is that, number of ED visits in a year, those return visits. So that would indicate that things are making marginal improvements, perhaps.
Sorry, my computer is being all crazy. Thank you so much. And thank you guys. It's really been a great engaging conversation. And there's one more comment. Dr. Hirschler said, I wonder if mentoring program with patients who are in COAT and have done well for years could work with the orientation patients to help engage them. It's an excellent comment. Thank you so much. Does anybody else have any comments or questions before we close?
I'll just say quickly, that was a really interesting part of your presentation, Megan, that orientation program. So if there's ever a chance to get details on that, I'd be interested in knowing more about it.
Yeah, absolutely.
Excellent. All right, the next time we're going to meet will be June 26th, and Olivia Higdon will be discussing psychedelic assisted psychotherapy. So I look forward to seeing you guys then, and have a great rest of your week.
Thank you.
Yeah.